Well, and welcome back to our final podcast from CROI 2023. And I can't think of a better person to have on the show to wrap us out than Meg Doherty. Meg is the Director of Global HIV, Hepatitis and STI programs at the World Health Organization. She and I have worked with each other for most of the last decade, and she's just one of the most articulate clinical scientists who is able to move communities at the same time. So I've been trying to get her on the show for quite a while. So Meg, welcome.
Thank you for having me. I'm so excited to be here.
So what we're going to do in this particular podcast, if it's okay, is just sort of look at how you saw the science presented here this week, what really stood out to you, and then also cover a couple of key questions, because obviously 3 years into COVID, WHO is playing such a crucial role in managing global health in ways we had perhaps never imagined. So, first line, why were you here? Did WHO have data that was presented?
Well, WHO always loves coming to CROI, and we use it as an opportunity to learn about whatever the new science that's coming out, how it can be translated into guidelines. And so this time around, we did not bring new science, but our job as WHO primarily is not to be creating the evidence, but is to be synthesizing the evidence that's brought forward. So our job this time was to take a look at all the new studies that are coming out. And we use the opportunity to meet with partners, researchers, community members to talk about some of the new guidelines that we're planning. One in particular around PEP, or post-exposure prophylaxis for HIV. Another around, we have guidelines around long-acting cabotegravir for PrEP, but what are the next steps? And I think because we're now the Department of HIV, Viral Hepatitis, and STIs, we really wanted to be here to learn the science about doxy-PEP for prevention of STIs, the meningococcal vaccine for prevention of STIs, and to learn about even some of the long-acting drugs that may be coming down the pipeline for hepatitis C cure and Hep B cure. So there was so much exciting science for us to help us take back and think about the next step in our guidelines for global implementation.
So starting then perhaps with the long-acting injectables, guidelines for treatment need to be updated and reflected. How do you think long-acting for treatment is really going to affect, the people that, frankly, WHO is most concerned about, people in the global south?
Well, we've been discussing this quite a bit, and I actually just came from a meeting discussing some of this, because there was some important studies that were shown, the SOLAR study, an interesting study that came out of ANRS just today, about people using long-acting cabotegravir with rilpivirine, some of the good experiences, the non-inferiority, some of the challenges with it not being able to have high troughs if there's not a oral lead-in to that therapy, some failures that are coming out. But on the flip side, yesterday we heard from Monica Gandhi, who has been using this drug to save people who had no other choice and were going to be dying from AIDS if they didn't have access to a long-acting therapy.
I am so glad you mentioned Monica's presentation. It was done in San Francisco. Mm-hmm. One of my other hats, and they'll kill me if I don't say this, is that I'm chair of the San Francisco Community Health Center, which is really ground zero for providing HIV prevention and treatment services to the homeless and to the mentally ill. And CAB-LA is potentially a game changer, potentially.
Well, I think, for us, we really look at it in two pieces, and that they're the same drug, CAB-LA, for prevention, where we've already made a recommendations. But then CAB-LA paired with rilpivirine, which is a really big, both of them require cold chain, well, rilpivirine in particular is a big shot, that's for treatment. And I think we have to be really careful about how we look at where the injectable treatments with these molecules will go in the future. And what's exciting is that J&J with the cabotegravir with ViiV are doing some studies in Africa right now. There's the Affinity trial among adolescent girls, I believe, with Linda Gale Becker, or adolescents in general. There's another trial that is gotten underway, CARES, which is going to be looking at values and preferences. How do you deliver, a cold chain needing injection into the buttocks, every 2 months? How well is this taken up? Do people want this in those settings? What's the appropriate population? Is it among those who are really failing as a salvage therapy, or could it be for populations who are having trouble? And adolescents have been brought up as a potential population. And then there's another trial getting started as well in the same communities. I forget its name, but it's nice to know there are at least 3 trials getting underway for the use of long-acting treatment with the molecules that are available right now. I think for WHO guidelines to change, we'd like to, ideally, we want to be prepared for molecules that are new, that don't have cross-reactivity to dolutegravir. We've just made this huge movement of now 26 million people are taking a dolutegravir-based regimen or so.
26 million.
I may have that wrong. 26 million people on treatment.
And a good proportion
And
of
a
them
good
are
proportion,
on,
but it's something like 90% or more. There's still pockets that don't have it. And I think what's, at least in sub-Saharan Africa, that transition has been transformational. Let's say viral load suppression is going way up. Children who are now on dolutegravir, viral load suppression has really skyrocketed in terms of percent suppressed. So it's been a game changer. But I recognize the need for choice. I recognize that there are needs for populations who have not been able to be taking an oral therapy daily, and that there is a role for injectables. We would like to see an injectable with a small molecule that's not cross-reacting to the integrase inhibitor of dolutegravir. And some of those we think are on the pipeline, and we're looking forward to those trials when they come to fruition.
Just one question, if I may, around the dolutegravir question. Much of the research had been conducted in looking at 2 agents rather than the usual 3. In the global south, and the majority of people who are taking dolutegravir-based regimens, are they taking double or triple therapy? Do you know?
Most people right now are taking triple therapy. So I would say what has been invested in is the combination of tenofovir, lamivudine, and dolutegravir as a fixed-dose combination, 1 single pill a day, called TLD. So my understanding is the majority of the population is taking triple therapy. We do know that there is a lot of data that have come out from various studies, and I'm sure it's being utilized in many parts of the world where it's either 3TC and dolutegravir. And we have not made that recommendation for low and middle income countries as of yet, because number one, I don't believe we yet have a generic regimen that would be at the same cost of TLD. With TLD, for many of the countries now who are getting their antiretrovirals with the support of either their country or PEPFAR or Global Fund, are paying somewhere between $50 and $60 per year for an entire course of treatment. So you would have to match that price with any new drug in some ways to displace that. But on the other hand, it's very good that it covers, it's been seen to be very robust. And at the same time, when you have the tenofovir on board, you're also treating those hepatitis B cases that are not yet identified. And one thing we do know is hepatitis B, there's, nearly, 295 million people living with hepatitis B. Only 10% know their status. So we have a lot more work to do there as well.
Now, right at the start, you mentioned PEP, post-exposure prophylaxis. What were the data that really stood out to you this week?
I would love to say that I went to all the PEP abstract sessions, and I didn't, But I would
But
have
your
to
team
say,
did.
my team did, and I would have to say that what I heard about, and I've had a reach out to say this is great, is PEP in Pocket. And there was a poster on this. What we know about PEP, post-exposure prophylaxis, is that people, it's good if it's in your hands and that it's available to a person when they have an exposure. And so often PEP has been limited by needing to go to an emergency room, go to say that they've had a sexual assault or an exposure, and they may be faced with stigmatizing healthcare workers, and so therefore they may never go. And so the idea of getting PEP into people's hands is kind of like we were talking about, it's like B+ or emergency contraception, option B, or plan B.
Plan B, yes.
Getting them all confused. Plan B, emergency contraception. People can walk into a pharmacy and no questions asked about behaviors. Here's your contraception, your emergency contraception. We would like to see something similar for PEP, that people, if they have had an exposure that they're concerned about, whether it's through an assault or through just a partner they got to know that night, that they have the option to walk into a place and have PEP available to them. So my understanding is this innovative study is giving people PEP. So if they're going to have an exposure, they have it in their pocket so that they can use it if they're feeling that their exposure requires PEP.
How interesting. And the other thing that's so interesting about this, it speaks to, I think, the real value of CROI, is that in many ways, the poster presentations are really where the action's at. And the ability to go around and chat to presenters and researchers in detail outside of the formal session room is something that's really valuable, isn't it?
I think that's what everybody has said. They've been so happy to, number one, see people, recognize them and say, it feels like 3.5 years or 3 years have gone so quickly, yet you recognize your colleagues. Number two, I think I've been so impressed by all of the senior researchers, the sessions, from Fauci sessions to everyone others, sort of trying to pass the baton of this is where science happens, this is where young investigators need to talk with the older investigators and get inspired to do something new and different. And so that was also really, it was nice to see and inspirational, so that we know that HIV research is in good hands as it goes forward. And now combined with hepatitis, STI, COVID, Mpox, etc.
So the other thing that has really struck me about this week, we're here in person for the first time in, 4 years, 3 years, 4 years. But it strikes me that after COVID, clinical science can't live in a vacuum. And the idea of us having a safe space to explore that science, that's good, but it's necessary, but it's not sufficient. And you can see this in strategies, as we spoke about, for long-acting, but you can also see it in the way Mpox has been handled, and of course the STI, pardon me, the STI treatments. And I guess, from a WHO perspective, it's really public health, taking the science and then applying it. Have you seen, really, since the emergence of COVID, a change in the way that you are thinking about how you communicate science to a broader public?
Absolutely, absolutely. I think, from WHO's perspective on COVID, no matter what the population might say, WHO changed. There was a fundamental shift in how the DG would come forward, weekly press briefings, Mike Ryan, Maria Van Kerkhove, all there to answer questions. And I think that has now translated into weekly. There are press briefings on the latest emergency, the latest outbreak, the latest innovation in science. And what I've seen is all of us were going to whatever social media you follow, or listening in and realizing how complicated it is to take a scientific fact or something you've seen in a research project or outcomes, and translate that into something that everybody understands. And then know that every other week it may change as new science came in. I think the other thing that was so incredible about COVID is you saw how quickly science was shared. And every day you needed to be updated to date with what was new and try to be able to sort through what was new and important and what was new and not so important. So I also appreciate the scientific journalists who kept us all informed as well, who really digested a lot of that, and sometimes had a much clearer voice than those who are doing the science. So yeah, I think we all have to be able to communicate our results, our science, where we want to go, what the impact and the implications of science is for populations, and then learn how to be flexible to change those messages as science changes. I think it's the population that also has to understand that science changes, and maybe they are starting to do that, but not enough, I guess, and hopefully things like this, the podcast, will help change that view that science is something we all have to learn how to digest and accept that it changes with time.
We were talking to Heidi Larson just prior to this podcast, and I asked her specifically around how do we change the public's understanding of clinical science as an iterative journey. You know, we build evidence and that may change. And, you know, the primary example is Tony Fauci. Don't wear masks. And then a month later saying, everybody wear masks. And of course, this was what the data, you know, as we were learning, this was what was telling us. But it's that need to explain to people, particularly as we move into an era of new pandemic threats, that we're sort of learning as we're going.
I think that's a huge challenge. And I do think that scientists probably need to be trained on how to do this well. But with the how to address the infodemic that can happen where bits and pieces are taken and, expanded or misinterpreted. We have a whole new department of infodemic at WHO, and there are communications experts who are really trying to say, we've heard this message, try to adjust your messaging, use this language. During MPOX, for example, we were brought in very early because our department had experience through the HIV work that we do of working strongly with communities, understanding language, understanding stigma and discrimination. And so they asked us to come in very early. So we worked with the risk communication and community engagement team that works on emergencies. And I have to say, there are some very good tools that they use. How do they get the information out? They're networked through journalists, through social media channels. And I think that's where we probably, as scientists or WHO or public health specialists, don't spend enough time there. And you'll see how some really excellent clinicians during a period of time became social media stars. And it's good if they can communicate well. And so I think, for example, with Tony Fauci, I think the population has to be very, very forgiving because science changes. And so if every day you come in and say, we have new information, I'm going to tell you what the new information says, it's not because the other information was wrong, it's just, it progresses. I think it has to be said over and over and over. And if you listen to Mike Ryan, he says the same thing over and over and over. But I think that consistency is helpful for the public to get the message through.
I've got to say, I think this is something that WHO did really right. And of course, I mean, you said that the scientists need training. Well, perhaps so do the politicians. But at the early stages of the pandemic, when it was really not clear what was coming out of the United States, so many of us turned to those briefings that were happening at WHO. And the Director General, Tedros, I mean, he was there, right out there, talking about it and handling some of the controversies, the trip to Wuhan from the experts, and that whole issue of where did it come from. And I just a shout out to say that I think, you all turned on a dime and handled this really exceptionally. And it sort of leads us to where we go with WHO from here. And I know one of the questions that our co-host Yvette Raphael wanted me to ask was, what has WHO got planned for this year? There's the big WHO coming up, and WHA coming up, World Health Assembly. And there's a lot of stuff in that that's of huge interest to the communities. The pandemics treaty, there are resolutions, particularly the resolution around diagnostics. Yay. And I just wondered, what's coming up, what's of interest to you? And then I want to come on to what resourcing we think we need WHO to have moving forward.
Okay, these are the easy questions now. Thank you. But WHA, it's the 75th anniversary of WHO, so there will be a celebration of WHO. We just got through what's called the Executive Board, which is sort of the mini pre-WHA. And so that's an opportunity to see all the new resolutions, all the priorities coming forward. For WHO, it's, again, the DG, Tedros, Dr. Tedros, is now in his second term. He's put forward his 5 priorities. They're called the 5 Ps. Don't ask me to repeat the 5 Ps here. But it's focused, I can tell you, the focus is still on the triple billion, if you've heard about it, keeping 1 billion people safe from emergencies, 1 billion with health promotion, and 1 billion with access to the necessary services for healthier lives. And, I think health promotion is taking a bigger stage at WHO. But also, I think some of the issues around how we can maintain the activities of WHO through a very sustained funding mechanism that's going to come up, as well as the pandemic, not calling it a treaty, the pandemic process, document, etc. It changes all the time is what I understand. But I think it's to really put forward how can WHO and other global health and funding architecture out there respond better to emergencies, not have a cycle of where we have an emergency, we put all of the work into the emergency, and then we step back, and then it comes forward again. So a greater sense of surveillance, and they've invested quite a bit into both genomic surveillance, epi-surveillance, to be able to understand when new emerging infections may be coming out, or and as well as working with the World Bank on this fifth, or this funding mechanism, to have enough funding available to address pandemics as they become as they manifest. The other big resolutions you mentioned, there's a resolutions on diagnostics. I think this one is about ensuring that we don't have what the challenges we had with COVID, where you had diagnostics available in high-income countries, not in low-income countries, ensuring that we have what we call multiplex diagnostics, diagnostics that are available for emergencies, using the platforms and the networks that are already available around the world. They're not diagnostics just for HIV viral load or TB, but they're for the viruses or the bacteria that need to be identified at the time. The other one that's of interest is there's a resolution around clinical trials, which I think also speaks to how do we get prepared for the next pandemic or health security issues. Because with COVID, there was a huge amount of science, but there was a huge amount of disorganized science. There were trials all over the place, not necessarily in great, organized across countries. And I think the idea here is if you can do and have platforms that are already set up for collaborations, so there's not competition, but there's really enough data early on with enough numbers to be able to tell you about certain drugs, certain interventions, or certain vaccines when and if a new pandemic comes up.
It's funny, you're talking, and what you say makes total sense, and it makes me think of the AIDS movement in the late 1990s, when a lot of information was coming up around treatment, and an extraordinary mobilization of community journalists and this whole movement around treatment literacy. It's where I guess I really learned my stuff. And isn't it interesting that HIV is the gift that continues to give?
Well, all the time people will say that, in the monkeypox response, well, if we don't have the communities here that have worked with HIV in the past, we wouldn't know where to go. And the same, Mike Ryan would say the same thing about go to the communities first if you want to get some of the answers about how to do this work well. And so, and that is in delivering emergency care, for example. They were going into Turkey and Syria, and you said, we need to go to the communities first because we can do a lot of things on a plan, on a paper, in a office, but you don't make the impact until you are actually working side by side with the communities and listening to what the needs are.
Just one final thing on diagnostics, because as you'll recall, I bang on about it. I know very little about it, but I was sort of surprised, I think, during the course of COVID that people thought that we actually had sort of like, Star Wars or Star Trek tricorders that could go amongst the people and test, and you'd know everything there was about them. And there didn't seem to be enough of that sort of hub and spoke around optimized laboratory systems that were talking to each other, plus the sort of outreach with the point of care tests. And I mean, so first of all, would you agree with that sort of representation of the way the world was thinking? And what do we do? And this is, for me, the really exciting thing about having the resolution. Do you think we're going to be able to really develop a commitment and an understanding towards what we really need to do with a broader diagnostic strategy?
Well, I'll take your last question first. I hope so. I mean, the idea under the diagnostics resolution, and I've read through it and I understand bits and pieces of it, it's definitely where it will hold member states accountable to having and developing cross-cutting platforms, for diagnostics, and that there will be regulatory that will be easily available, and so that you wouldn't just develop a one-off test here and it's being used in Europe, but it can't be used in Africa, but that we can use the platforms that are available, whether they're I think a lot of the diagnostic platforms now are based on PCR and nucleic acid, and that's revolutionizing, where you don't have to have that much blood or sample to be able to get a good result, and you should be able to do that for many different infections.
Just good throughput.
Good throughput. I think going back to the first question about how can everybody know about their COVID? I think it was a tough time, and it took a bit of, people were using self-testing, sort of everybody was using self-testing. And I think that it's a good thing in some ways, because WHO in our department, we've had self-testing guidelines for HIV. And during COVID, we came out with self-testing guidelines for hepatitis C. And we're planning guidelines around self-testing for hepatitis B and syphilis. We feel that self-care is sort of the new thing. And we helped develop that recommendation around COVID self-testing that came out of WHO. We think self-care is an important thing, putting information in the hands of people. Then how do you capture that data, though? I think that's the question. If public health people want to know, how do you plan what's happening with the spread of an infection? If everybody's doing it in their home and not reporting it, you're going to be left without a lot of information about how to prevent the next outbreak or ensure that you're delivering services to the right place. So there also needs to be a bit of a, let's say, on self-testing, a reporting in, a responsibility of individuals, if they know that they're affected, to report it in, to ensure that they're part of a public health system, that you're taking care not to infect others, etc.
And building trust to encourage people to do that.
Yeah. Absolutely.
So changing tack a little bit. On balance, I think WHO has really risen to the challenge over COVID, and I think, all credit to you and your colleagues. And I think there's a real need for advocates like myself, like Yvette, to really be pushing our national leaders to fully fund the WHO. To me, there's absolutely no question about that. But changing tack a little bit, and this is one of the things that Yvette wanted to just get your thoughts on, as a woman leader in the WHO, UNAIDS had its issues, WHO has had its issues around employment behaviors, and particularly, cases of abuse and just how do you see WHO responding? And I guess, both you and I have had experience of working in the UN system. How do we make the system fit for the 21st century, fit for purpose?
Well, I think it's a really important question, and it's something that in our department, and I think WHO writ large, we think about a lot. And during the time when the information about what happened during the Ebola outbreak came forward, that happened mid-COVID outbreak, I think it really touched the people in the emergencies department because they're really working day in and day out. And nobody wants to see this behavior at all. It's a horrific behavior, sexual exploitation, abuse of power. It really should not be happening in this day of age, in 2023, at all. And then sometimes I'm wondering, where have we all gone wrong? And as an institution, I think we have to congratulate Tedros and the administration because they've set up a new program around prevention and response to sexual abuse and sexual harassment and abuse of power. We all are taking training regularly, have to demonstrate that we've taken the training. As leaders, we have to be aware of our responsibilities, duty to report, and in many ways modeling the right behavior. And I think it will take some time, but I'm confident that there's been, at least recently, a greater transparency about the time it takes from a report to go in to action happening. And what I understand now, there's an open portal. You can see how many complaints have come in, the time it takes for them to be resolved. And, I think that transparency is what people wanted to see. If this happens, there's going to be action, and that they will not have to see that person ever again in their setting if after investigation everything is shown that this was an inappropriate behavior.
And that they're protected and
that their managers, their leaders, their supervisors will report, even if they feel uncomfortable about reporting. And I think there had been, quite a few cases where young women, young men, whomever, people who were not in the position of power, who felt that their ability to move up in the organization or their careers in public health could be affected by speaking out. And, we have to give kudos to those who are speaking out now, and we have to give kudos to the WHO who's taking it seriously and making it transparent. And I think, sometimes I just wonder, I'm like, have people in any organization where this is still happening, are they living under a rock? What has happened? So as a woman leader, I want to make sure that we're modeling the right behavior and we're addressing it quickly and immediately. But still to say, there's a lot of residual discomfort that people feel and worry. And so it's going to take some time to get that trust fully back.
Well, thank you for answering that so directly. Just one question that immediately comes to mind. I remember when you joined WHO, and you came from Johns Hopkins, I think, didn't you?
Correct.
And I remember talking to a colleague of yours at Johns Hopkins, who will remain nameless, saying, how long do you give her? Oh, I think she'll do 1 term. But here we are, or a couple of years, maybe 4 years, but here we are, coming up for a decade later. How have you stayed motivated at WHO?
That's interesting.
I just threw that on you, and I'm sorry.
Yeah, no, it's fine. Because to be honest, I did come to WHO on a leave of absence from Hopkins, where I was on faculty for infectious diseases. And I love clinical care. I love being a doctor. And so I said, okay, I'll do 2 years and see what it's like. I think what happened to me, I don't know, it goes quickly. Number 2, it's a real privilege to be working in WHO. And so I think I recognize the importance of bringing what I think is so important about trying to get to the end of HIV, which was sort of a career passion, a lifetime passion, that I could do a lot more by being a driving force at WHO. I mean, it's not always easy at all because big bureaucracies are never easy for people who want to see change immediately. And so in many ways, I guess I'm surviving because the passion is still there that we are getting closer. And we've seen some countries who are on the path to elimination for mother-to-child transmission. We may have a country on a path to elimination of hepatitis this year. You know, and that we've seen huge changes in the regimens that people are taking, and I think it is changing people's lives. So that keeps me motivated to know that what our recommendations may be will change people's lives. And I think the other thing that we've done is WHO was considered, I don't know if it's true or false, you know, as being very slow to change. And I think over the last years, we've become faster at changing, taking new science. And if I have any element of helping to do that, I want to continue to do that because I think we have a responsibility to make sure that what happens in high-income countries happens in low-income and middle-income countries at nearly the same pace. So, and we've taken our cue also from COVID. We're moving quickly on new guidelines as well. And I think that sort of mix of science, activism, understanding community needs is what keeps me motivated because I think you can do a lot at WHO and you can bring the best experts around the table to help you answer really difficult questions.
Yeah, totally. Well, look, one last question before we let you go. It's been a long week. It's been a really intense week. So, are you binge watching The Last of Us on HBO? It's the dramatization of a game of a sort of zombie apocalypse, this time caused by a fungal infection that transfers from ants to humans. What do you think of it?
Well, I have to admit I haven't watched it, but it sounds like I need to watch it. And I still am just getting through, what was it, Breaking Bad. I almost finished. Now I never watched Games of Thrones, and I'm watching Ozark a little bit, but I have to say the zombie apocalypse sounds too intriguing, so I'm gonna have to go watch it now. So
Absolutely.
I haven't seen it yet.
Oh, so if you're getting to the end of Breaking Bad, you're going to go to Better Call Saul afterwards?
Okay. Thank you. But the fungus is too much to resist. I'm gonna have to jump over Better Call Saul to the fungus.
Meg, thank you so much and all the best for your work and really looking forward to checking in with you later in the year. Thank you so much.
Thanks for having me. It's been fun. Thank you.